So hope all are here. We'll try to give, I know I'm not with you in a physical face to face, but still we'll try to interact with each other maximum. And when you feel tired, you can just message me or just send me some comments so that I will give you that 3 minutes break uh, and we'll proceed. So today we are going to learn three topics. Heme. One is heme. The second is phospholipids, and the next one is we have to learn about the glycosaminoglycans. So these are the three topics we are trying to finish today. So first, so should I wait for more or I'll start, right? Okay, so if I'm not audible or any technical issues are there, kindly give me a message so that I will do accordingly. So we are starting first with the heme synthesis. This is a very long, lengthy pathway, but you don't have to learn this pathway. But there are some porphyrias here, and there are some features of porphyrins. Only that you have to learn in heme synthesis and the porphyrias. Okay. So first, I will introduce to you who is a heme. Heme is actually a combination of two things. One, you can see it is a metal. What is a metal? Karun is here. Karun, help me. What is a metal in heme? Ajmal. Ajmal vanished. Arjun, can you tell me what is a metal in heme? Hi. What happened to you? All very silent. I'm asking you some question. ഇത് ഓൺ ആക്കിയിട്ട് എവിടെയും പോവല്ലേ? ഞാൻ ഇടയ്ക്കിടയ്ക്ക് ചോദ്യം ചോദിക്കും. ഒരു ചാറ്റ് ബോക്സ്. ഹലോ. Iron. Okay. Oh, okay. Right. Iron. So we are going to see something which is combining with iron. Who is combining with iron? ശ്രീഹരിനെ മറന്നിട്ടില്ല നവജീവൻ. Who is combining with the iron in heme? Okay, protoporphyrin. So how can we name an iron as? Iron is otherwise? Sorry, heme as. Heme is otherwise? Ferro, proto, porphyrin. Okay, ഇടയ്ക്ക് സംസാരിക്കാം കേട്ടോ. ഒന്ന് അൺമ്യൂട്ട് ചെയ്ത് ഓക്കെ എല്ലാവരും മ്യൂട്ട് ചെയ്ത് വെച്ചേക്കാണോ വിമൽ?
ജസ്റ്റ് വെയിറ്റ് നോക്കട്ടെ.
എല്ലാവരും മ്യൂട്ടാണോ? ഓക്കെ ഓക്കെ ഓക്കെ. അവർക്ക് അൺമ്യൂട്ട് ചെയ്യാൻ പറ്റില്ലേ?
പറ്റുമല്ലോ, പറ്റും മാം.
ഇടയ്ക്ക് ഞാൻ ചോദ്യം ചോദിക്കുമ്പോൾ അൺമ്യൂട്ട് ചെയ്തിട്ടൊന്ന് പറയണം കേട്ടോ. അല്ലെങ്കിൽ നമ്മളിങ്ങനെ വെറുതെ ഇങ്ങനെ ക്ലാസ് എടുക്കുന്ന പോലെ ഇരിക്കും, ഒരു രസം ഉണ്ടാവില്ല കേട്ടോ. ഓക്കെ, സോ ഹീം ഇസ് എ കോമ്പിനേഷൻ ഓഫ് ടു തിങ്സ്. വൺ ഇസ് അയൺ, ദ സെക്കൻഡ് ഇസ് പ്രോട്ടോപോർഫൈറിൻ. ഓക്കെ, സോ ഇങ്ങനത്തെ ഡീറ്റെയിൽസ് ഒന്നും നിങ്ങൾ അധികം അറിയണ്ട. ദർ ഇസ് നോ നീഡ് ദാറ്റ് യു ഷുഡ് ലേൺ എവറിഥിങ് ഇൻ ടു ദ കോർ ഓഫ് ബയോകെമിസ്ട്രി, ബട്ട് ജസ്റ്റ് an overall understanding, that is enough. Okay, so heme is metalloporphyrin, where the metal is iron and the porphyrin is protoporphyrin, as you rightly said. Okay, who said that? Sibin. Yes, as you rightly said, it's right. Okay, so we understand that what is we know what is iron. So what is a porphyrin? Porphyrin has four rings in its structure. It has four rings in its structure, and that ring is called as, each one of that single ring is called as pyrrole. So four pyrrole rings join together in a cyclical manner like this to form what is called as porphyrin. So there are three major porphyrins. So we usually learn it as UCP. What is it? UCP. Okay, what is U, what is C, what is P? If you say, I will write here. So this is what we are writing here. Please take that notes also, okay? That I have given, handwritten notes. So please take that with you. So I'm going to write the three types of porphyrins here. You have to tell me. Yes, uroporphyrin, yes. Then copro and proto. Okay, always remember this order. So that is uroporphyrin, coproporphyrin, and protoporphyrin. Okay, so these are the three porphyrins. Always remember that order, U, C, and P. Okay. Right. Next, what we should have an understanding is that in our body, there are different isomeric form, but in our body, the isomer that is present is type 3 isomer. That is why we say protoporphyrin 3, uroporphyrin 3, etc. So these are the two things that we have to learn. First, learn the order U, C, and P, and then you learn type 3 isomers are present in our body. Okay. Now, we are going to see some characteristics. Why we are learning these characteristics? Because we want to identify a case of porphyria. So if we want to identify a case of porphyria, we should be knowing what are the characteristics of porphyria. That is why we are learning characteristics of porphyria. Number one, porphyrinogen. Porphyrinogen means, just understand that's a precursor. Precursors you have learned, right? So porphyrinogen is a precursor. Porphyrin is the active form. So porphyrins are generally colorless, colored compound, whereas the precursor form is colorless. Okay, so a precursor is colorless, but the active form is the colored compound. That's the second thing. So what is the importance of it, or what are the significance of it? Which means, if we have a case of porphyria, then colored urine. So if porphyrin is excreted in urine, we will get colored urine. So one classical example for that is port wine colored urine in porphyria. We'll write the short form, porphyria cutanea tarda. So this is one example. So which means that if we have colored urine, if we say patient with colored urine, that is one indication that there is a chance for porphyria. Number one. Then it emit red fluorescence. What is the importance of this emitting red fluorescence? So if we have any tissue sample or any blood sample or urine sample, so whatever is it. So I'm just taking a urine sample here. Okay, so in this urine sample, if there are porphyrins, what will happen? If you illuminate this urine or whichever specimen we have with UV light, then what is emitted out of it is a red fluorescence. Red fluorescence. What does that mean? So if we want to identify porphyrin, we just have to illuminate it with Wood's lamp. So what is Wood's lamp? Wood's lamp is an instrument from which we can get Wood's lamp. So Wood's lamp illumination means we are illuminating it with UV light, and what is coming out? The color is called as red. That red fluorescence comes out. So that is again an identifying feature. So sometimes in the question, if it is given a teeth or any liver sample, or a urine sample or blood sample illuminated with UV light, red fluorescence coming means chance of porphyria. Okay, that's the second thing. Next, it can absorb a light, and this is not UV light also. Okay, so please cut that. It is not UV. So it can absorb light at 400 nanometer, because 400 nanometer is not UV range. So that this 400 nanometer is actually visible light. Okay, so if you illuminate it with the visible light spectra, what will happen? What comes out of, or what comes after passing through this sample which is having porphyrin is that sample, in that sample or in that light which is emitted out, one particular nanometer will be missing. Which is that missing nanometer? It is 400 nanometer. So 400 nanometer will hide when we illuminate it with the visible light, and that is called as, so which we can see it as a absorption. That is an absorption band. You can see at which nanometer? 400 nanometer, which means this absorption band is called as Soret band. Again, another identifying feature of porphyria. Okay, so illuminate it with the UV light, red fluorescence. With visible light spectrum pass, one light will be missing, and that will you can see it as a sharp absorption band, because there are instruments where you can find the absorption band. So that is called a Soret band. Next is, it causes photosensitivity, because most of the porphyrias, we used to say that the patient exhibit photosensitivity. So why there is photosensitivity? The photosensitivity is because this is a feature exclusive of porphyrins. Porphyrins are there, then photosensitivity is there. Why? It's because if there are porphyrins in the cell, so if there are porphyrins in the cell, what will happen if light is falling on this tissue? Then what happens is this porphyrins will produce free radicals. Will produce free radicals. So if it produces free radicals, it is going to damage or degranulate an organelle inside this cell. And what is this organelle? This is lysosome. Lysosome തൊട്ടാൽ കളി കാര്യമാകും. Why? Because lysosome is having, it's a bag of membrane which carry all the hydrolytic enzymes. So if it is going to degranulate or destroy this lysosomes, then what will happen? All the hydrolytic enzymes will come out. Now, when the hydrolytic enzyme comes out, what will happen? It can eat away the carbohydrate, the proteins, nucleic acid, which means our cell is made of all these things, carb, proteins and all. So these enzymes come out means these cells will be destroyed, which means if a patient is having a porphyria where porphyrins are present, what will happen? If we if that Body part is exposed to light, then light falls, lysosomes degranulate, and those cells will be destroyed. So how can we see, or what symptom that you can see that in a patient, that is called as photosensitivity. So that is another characteristic. Same thing is, so because of the same principle, we can use porphyrin in a condition or in a special situation that is called cancer phototherapy. It's because the same thing. If we have a cancerous tissue which we can expose to sunlight, what we'll do is we'll inject porphyrins into the cancer tissue. Now, can anybody tell me what will happen? Can anybody tell? Please tell. ഒരു ചാറ്റ് കാണാം. പറയൂ. You can tell me what will happen. കുറേ മെസ്സേജസ് വരുന്നുണ്ട്. വിമല, എനിക്ക് കാണാൻ പറ്റുന്നില്ലല്ലോ മെസ്സേജ്. Okay, can anybody tell me? കുറേ മെസ്സേജസ് ഉണ്ട്, പക്ഷെ ഒന്നും കാണുന്നില്ല.
എക്സ്ക്യൂസ് മീ മാം. മാം
Yeah.
ചാറ്റ് ബോക്സ് കാണാൻ പറ്റുന്നില്ല.
ഇല്ല, അത് ലേറ്റസ്റ്റ് മെസ്സേജ് കാണുന്നില്ല. ഓക്കെ, കാണുന്നുണ്ട്. ഐ മീൻ ഐ ക്യാൻ സീ ദാറ്റ് മെസ്സേജസ് ആർ കമ്മിങ്, ബട്ട് ഐ എം നോട്ട് ഏബിൾ ടു സീ.
ഒന്ന് സ്ക്രോൾ ചെയ്ത് നോക്കാവോ?
ഓക്കെ.
മാം ക്യാൻ യു പ്ലീസ് ഒന്ന് സെൻഡ് ചെയ്ത് തരാമോ? ഫോട്ടോ ഒന്ന് അയച്ചു തരാമോ? എന്താ
അല്ല,
സിറ്റുവേഷൻ?
കുഴപ്പമില്ല, സാരമില്ല. ആരെങ്കിലും അൺമ്യൂട്ട് ചെയ്ത് പറഞ്ഞാൽ മതി. ഡോണ്ട് വെയിറ്റ്. ഹൂ വിൽ അൺമ്യൂട്ട് ആൻഡ് സേ? ശ്രീഹരി എന്നെ രക്ഷപ്പെടുത്തു. മാളവിക, അർജുൻ. എവിടേക്ക് പോയോ എല്ലാരും? പറഞ്ഞേ. ടെൽ മീ. ആസ് യൂഷ്വൽ എല്ലാരും സൈലന്റ് ആയി. പറയൂ മക്കളെ. ടെൽ മീ. അർജുൻ. ആ, ഓക്കെ. അർജുൻ ഒന്ന് പറ. അർജുൻ പ്ലീസ്, വാട്ട് വിൽ ഹാപ്പൻ?
Cancer cells will die.
If there is a cancer and if we inject the cancer cell will be destroyed, right? When we expose that cancerous tissue to the sunlight. So that is why we use porphyrin as in cancer phototherapy. Okay. So this is just a introduction to porphyrin. So these are all the properties. So these properties we'll explore when we want to detect a case of porphyria. Okay. If that much is clear, we are going to heme synthesis. The first thing that we have to learn is where is this heme synthesis occurring? Heme synthesis occur in, that is very, very important, okay? Erythroid precursor cells. Remember, you write not in mature RBC, not in mature RBC. So it is only in precursor cells plus liver. Okay. So these are the organs where heme synthesis take place. Organelles, tell me, who will tell me? I've already told you. Where is this Srihari? Organelle, parayu. Srihari മുങ്ങിയോ? ശ്രീഹരി ഒന്ന് പറഞ്ഞേ. ഓർഗനല്ലേ നമ്മൾ പറഞ്ഞായിരുന്നു. That I've told you something like this. Hug, right? Hug pathways include heme synthesis, urea cycle, and gluconeogenesis. Okay, so that is it. Organelle is cytoplasm plus mitochondria. Okay. Now we will see the steps. No need to learn this pathway. Okay. It's very length. By seeing this lengthy pathway, you will be confused how to learn all these things. No need to worry. You don't have to learn this pathway. But there are few things that it's must learn. Very, very important. Okay. So we will start. Then ഞാൻ full പറഞ്ഞു കഴിയുമ്പോൾ I will tell you where are the points or which are the major porphyries that you have to concentrate on. Right. So let me finish that, then I'll come back and tell you about which are the most important thing that you have to learn. Okay, so the first one is the first starting substrate is succinyl coenzyme A and glycine. These are the starting substrate. What is the enzyme there? It's a very, very important enzyme. That enzyme is ALA synthase. Okay, this is considered as the rate limiting enzyme. Moreover, it is an inducible enzyme. Inducible enzyme means I've told you that gene regulation is possible here. That is induction repression. Quantity of the enzymes can be decreased or increased. So that is possible here. So it is an inducible enzyme. Then the next point is this enzyme require a very important vitamin. Can anybody tell me what is the vitamin here?
B6.
Yes, very good. ആരാ പറഞ്ഞേ എനിക്ക് മനസ്സിലാവുന്നില്ല. Okay, so that is B6. Okay, PLP is the vitamin in the ALA synthase. Okay, now we are going to see some of the clinical conditions here. Number one, if there is a B6 deficiency, this is very, very important. If there is a B6 deficiency, it causes what? There is decreased activity of ALA synthase. So if there is decreased activity of ALA synthase, it can cause X-linked because this gene is present in X chromosome. So this can cause X-linked sideroblastic anemia. X-linked sideroblastic anemia. This is a previous year question. Okay. Then, that is about deficiency. But at the same time, if there is increased activity, it is because of a mutation which is called as so it is because of a mutation which is called gain of function mutation of ALA synthase gene, then what will happen? Then it is not anemia, then it is called a porphyria. And this porphyria is again X-linked because this gene is in X chromosome. X-linked protoporphyria. Just know this name, nothing else. So that is increased activity. Okay. So that is what you have to learn in ALS synthase. Next, we go to the second enzyme. The second enzyme is where you can see two molecules of ALA is joining, and that enzyme is called ALA dehydratase. Okay. And this enzyme will gives off, like when these two ALAs join together, one water molecule is removed. That is why the name ALA dehydratase. അത് പഠിച്ചു കഴിഞ്ഞാൽ just forget about those things. And now what we are going to learn is some very, very important points are hiding here in this ALA dehydratase. Point number one, very, very important. This is inhibited by lead. Okay, so this is inhibited by lead. So, which means we are going to discuss a very, very important topic here, that is lead poisoning. Lead poisoning. So, when there is lead poisoning, what are the symptoms? The most important thing that we should understand here is there any porphyrins produced like by this step? Which is the first porphyrin that is synthesized? First porphyrin ഏതാണ്? കരുൺ മുങ്ങി, അജ്മൽ മുങ്ങി. ഇനി ആരെന്നെ സഹായിക്കുക? സിബിൻ ഒന്ന് പറയോ? ഫസ്റ്റ് പോർഫൈറിൻ ഏതാണ്?
Europorphyrin.
Yes, euro. Is europorphyrin synthesized till now?
No.
No, right? Which means porphyrins has not been synthesized yet. Which means if there is inhibition of enzymes early in the pathway, like in this case, lead poisoning, which enzyme is inhibited? That is ALA dehydratase is inhibited, which means porphyrins is not yet produced. So it's before the synthesis of porphyrin, means the symptoms are usually neurovisceral, but usually we say visceral symptoms. Like the most common symptom that you can get in lead poisoning, especially chronic lead poisoning, is abdominal pain. And the classical scenario or the history that you can get for lead poisoning is it's an occupational hazard that was asked in the last NEET exam. If you remember, that is a person who worked in paint industry or something, is messaging that he went to a doctor. Doctor advised him many things, and he's sending an SMS to his friend who's a doctor. And he's saying that he understood everything, but one investigation that he has given, he's not understanding, and that was europorphyrin. Okay, why europorphyrin? I'll tell you later. Not Euro, Copro. So in the investigation, the doctor prescribed Coproporphyrin. Why there is Coproporphyrin? That was his question. That was an SMS that he has sent to his friend who is a doctor. This is kind of things that you can see very commonly nowadays, doctor shopping and all. So if you don't understand what, then we will approach somebody else, something like that. So that was a question asked. So my point is, that is here in this lead poisoning ALA dehydratase deficiency, it is an occupational hazard, usually seen this in occupational hazard in enamel paint industry. Enamel paint. And another very important, usually the history that you can get is child who licks paint, licks toys, licks toys. So the toys has paint, which means the paint is having lead. Okay, so then also the chances of lead poisoning. So these are some of the histories that you can get previous year question based. So that is lead poisoning, and they usually present with abdominal pain. And what is the enzyme that is defective here? ALA dehydratase is the most important one. Other enzymes are also there. So in lead poisoning, what you can find is urinary ALA is increased. So I'm just saying urinary ALA increase because other enzymes have not yet reached. So I'm just saying urinary ALA is increased. So I hope you can understand why urinary ALA is increased. Okay. So that is what you have to learn. The most important thing, rather than learning any porphyria there, you have to learn about lead poisoning, very frequently asked for most of the exam. Okay. Now we come to what is the next. Is there any porphyria if there is a defect in this enzyme which is called ALA dehydratase? Yes. That porphyria is called as ALA dehydratase deficient porphyria. ALA dehydratase deficient porphyria. Okay. And this is otherwise we write it as ADP. ADP. Okay. And this resemble lead poisoning. That is self-explanatory. Hence, this is also called as plumboporphyry. It's also called as plumboporphyry. Okay. So that is about ALA dehydrated. This is what you have to learn. Next, we are going to a very big disorder. I have given some space over there. So first, that is the next step is, by this step, like two ALA joined together, what we get is a porphobilinogen. Somebody has given me permission to record to their computer. I'm declining it. Okay. Can you see my screen? A pop-up message is here. Can you see my screen now? Is that message visible to you?
No, ma'am.
No, right. Okay. So then I'm going to proceed. Okay. So don't send such messages to me. Don't disturb in between. If you record it to your computer also, you're not going to see it. So please attend the meeting and then only you will understand. Okay, fine. Next, going to porphobilin. So now what we got is porphobilinogen. Porphobilinogen, the characteristic thing is this porphobilinogen is having that pyrrole ring in its structure. So what did I say initially? We need 4 pyrrole rings, right? So porphobilinogen means that is PBG. So PBG has 1 pyrrole ring, which means what should happen next? 4 porphobilinogen. That is what is written here. 4 porphobilinogen joined together by giving off NH3, okay, ammonia, and it forms something called as hydroxymethylbilane. Hydroxymethylbilane is what is formed, okay. So hydroxymethylbilane, it is a linear tetrapyrrole, okay. So ammonia is released. So what is the enzyme here? The enzyme here is PBG deaminase or HMB synthase. Okay. Otherwise, this is called as uroporphyrinogen. You write it as short. In short, you can write it as UPG. This is UPG 1. Remember, it is not 3, it is 1 synthase. Why I have given you 3 names? Because this particular enzyme is having a very, very important porphyry associated with it. So I am just putting a crow's mark here. And I'm going to see what is the porphyry here. This is called acute intermittent porphyria. It is called acute intermittent porphyria. Okay. Now, my question is whether any porphyrin produced till now. If any defect in this, my question is whether there is any U, C or P here. Undo. Any U, C or P here? No, which means if there is a defect in this enzyme, will there be any photosensitivity?
No.
No, this is a very important concept that you should understand. That is, before that U, C and P, there is no photosensitivity. Okay, so what is acute intermittent porphyria? The enzyme defect I've already told you. So here what happens is there is increased PBG and there is increased ALA. So if there is increased PBG and increased ALA, what will happen? Then they will be having NV. What is NV? NV,
Neurovisceral.
neurovisceral. Okay, so they will be having neuropsychiatric symptoms, and they can have visceral symptom. So the most common visceral symptom is abdominal pain. Abdominal pain. Okay. So they will be having neurovisceral symptoms. Very important, you write here, there is no photosensitivity. This is a very important question. And what are the other peculiarities of acute intermittent porphyria? This is the most common acute porphyria. This is the most common acute porphyria. Then what we have to understand there is now this is very commonly asked. They usually have a history of drug intake. What is the importance of drug intake here? Can anybody tell me? I've already told you about this drug intake and porphyria. Drug intake and porphyria. Where is Teresa? Drug intake and porphyria. I have told you this.
Inducible.
Karun vannu alle. Karunu Ajmelu ഒരുമിച്ചാ? Okay. Okay. So inducible. Yes, inducible. Okay. So drugs, if we are taking, what happens? There is decreased cytochromes if it is using cytochromes. So if there is decreased cytochrome, there is decreased heme. So if there is decreased heme, then the gene for ALA synthesis induced. So if a gene for ALA synthesis induced in a porphyria patient, as there is a block here, what will happen? There is increased accumulation of porphobilinogen. So that is why very, very important history that you can get is history of drug intake here. Okay, so that is about the most common one, that is most important porphyria that you have to learn, acute intermittent porphyria. Okay, next we go to the next step, that is hydroxymethylbilane is now in a linear tetrapyrrole state. So you can see my hands 1, 2, 3, 4. So there are four pyrrole rings. Now they are going to cyclize. They are going to cyclize like this, and that step is by an enzyme called as UPG3 synthase. UPG3 synthase. So if there is a block here in UPG3 synthase, what will happen? Now my question is, if there is a block in UPG3 synthase, will it cause photosensitivity or not? This step if you see this step, and can anybody tell me, will there be photosensitivity or not?
Yes.
Yes. No, ആരും പറയുന്നില്ല.
No photosensitivity.
No photosensitivity ഉണ്ട്. Yes ഉണ്ട്. Okay. Yeah, I know the mixed answer will come here. Okay. Ideally speaking, hydroxymethylbilane should accumulate, right? That is what we expect. Yes, hydroxymethylbilane accumulate. So when hydroxymethylbilane accumulate, what will happen is there is an alternative route for porphyrins. That is, if this enzyme is not there, then this pathway become active. So when this pathway become active, it is producing not three isomers. Usually in our body, the three isomer is present. So instead of that, one isomer is produced. One isomer na ഒത്തിരി അങ്ങ് അറ്റം വരെ പോകാൻ പറ്റൂല. That means it cannot go up to the level of heme. It will stop in between. So it forms and how is it formed? It is because this route is spontaneous, which means no enzyme is required. So if there is an enzymatic deficiency, then spontaneously this hydroxymethylbilane is converted to uroporphyrinogen and coproporphyrinogen, but it is not 3, it is 1. So it cannot proceed further. It will stop there, and hence there will be accumulation of type 1 porphyrins. So type 1 porphyrins accumulate there. Now, which is evident that there is CP. CP means cutaneous photosensitivity, okay? So cutaneous photosensitivity is present here. Now, the question is, what is this disorder? Learn the short form. It is CEP. കുറച്ച് ലെങ്തി ആണ്. CEP. CEP is ആർക്കെങ്കിലും പറയാമോ? Congenital.
Erythropoietic.
Correct. Erythropoietic porphyria. Congenital erythropoietic porphyria. Okay. ഞാനൊരു ഗുണ്ട് പേരൂടെ പറഞ്ഞുതരാം. ഓർക്കാൻ പറ്റുമെങ്കിൽ ഓർത്താൽ മതി. ഇല്ല വിട്ടേര്. This is also called as Gunther's disease. ഗുണ്ട് പേരാണ്. Gunther's disease. Okay, if you can remember, okay, otherwise also fine. So congenital erythropoietic porphyria or Gunther's disease, and this has some peculiarity. Number one, this is autosomal recessive. എന്തിനാ ഞാൻ autosomal recessive പറയുന്നത്? It's because I'll tell you in a later session. Later I'll tell you why I'm saying autosomal recessive. Okay, this is autosomal recessive, and this patients usually present with these porphyrins accumulate in the teeth. So they present with brownish discoloration of teeth. They present with brownish discoloration of teeth, and the teeth itself is having one more peculiarity, that is when you illuminate the teeth with UV light, ara paraya, what will come out?
Red light.
Red light, red fluorescence will come out. So what is the name that you can give for this? Red in വേറൊരു പേര് പറയാമോ? Can you tell another name for red? There were few Telangana students, okay, that's for them I'm translating. Red in വേറൊരു പേര് പറയാമോ? Can I say erythro? Erythro പറയാൻ പറ്റുമോ? Erythro means red, okay?
Erythrodontia.
Midken. Erythrodontia. Dontia is always something related to teeth. So this is called erythrodontia. Okay. So this is another peculiar feature that you can see in congenital erythropoietic porphyria. Okay. So that is CEP. What is the enzyme defect? Enzyme defect? Enzyme defect? പറയൂ മക്കളെ, enzyme defect. Karun, Ajmal.
UPG3 synthase.
Midiki. UPG3 synthase. Okay. But that is the next. This is congenital erythropoietic porphyria. Okay. Now we are coming to another disorder where now we have this uroporphyrinogen being synthesized, which is converted to, now always remember UCP. Uroporphyrinogen is converted to coproporphyrinogen by an enzyme UPG decarboxylase. ഈ എൻസൈമിന്റെ പേര് പഠിക്കുകയാണ് ഇത്തിരി ബുദ്ധിമുട്ട്. That's the most difficult thing, to learn the name of the enzyme. So this is UPG decarboxylase. So during this step, 1 carbon dioxide is removed. That much detail you need not learn. Now, what you have to learn is what will happen if there is a defect here. So before telling that, let me tell you one more thing. That iron ഇവിടെ ഒരു കാര്യമുണ്ട്. What is that role of iron here? Iron can inhibit UPG decarboxylase. Iron can inhibit UPG decarboxylase. Lead can inhibit. Lead can inhibit.
ALA dehydratase.
ALA dehydratase. So iron can inhibit UPG decarboxylase. Okay. What is the importance of that? I'll tell you later. So if there is a defect in the UPG decarboxylase, it causes a very, 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 very commonly known porphyria. I think you know only this name every time when I ask about porphyria. That name is PCT. രണ്ട് പേരെ യൂഷ്വലി നിങ്ങളുടെ മനസ്സിൽ വരാറുള്ളൂ. വൺ ഇസ് PCT, the second is AIP. What is PCT? ആർ ജോർജ് ആരാ? റിയ ആണോ?
Porphyria cutanea tarda.
റിയ ജോർജ് ആണോ? ആർ ജോർജ്. Okay, what is peace? Yeah, Porphyria cutanea tarda. Yes, Porphyria cutanea tarda. Okay. First time you write the entire name, just next you learn the short form, that is enough. And what is the importance of this? This is the most common porphyria. കുറച്ചു മുന്നേ ഞാൻ വേറെന്തോ പറഞ്ഞല്ലോ. I told you something else. Now I am again saying this is the most common porphyria. This is mostly chronic. So whenever a question is asked most common porphyria or most common chronic porphyria, it is chronic porphyria, it is porphyria cutanea tarda. Okay. So this is most common porphyria. Then will there be photosensitivity? Of course, there is cutaneous photosensitivity. So that is why they are having monkey-like facies. And this is associated with hemochromatosis. Okay, tell me why it is associated with the hemochromatosis.
Iron is involved.
Iron, yes, iron is inhibiting this enzyme. So that is why it is associated with the hemochromatosis. Okay, so one treatment for this is also related to what we have said. It is phlebotomy. Okay, so that is porphyric cutanea tarda, right? Next onwards, you need not learn much details about that. That is coproporphyrinogen to protoporphyrinogen. The enzyme is CpG oxidase. Okay, so if there is a defect here, it causes, just know the name only. I'm not saying anything else. Hereditary. This is accumulating, so it is hereditary coproporphyria. Hereditary coproporphyria. Okay, that is enough. Next defect is, the next enzyme is PPG oxidase. So if there is a defect in this, just know the name only. It is causing variegate porphyria. Variegate porphyria. Okay. Okay, just learn the name only. Next, we are coming to an enzyme. Now we got protoporphyrin. So who should combine with protoporphyrin? Sibin? Sibin and answer. Iron should combine. So the next step is iron is combining here. Iron is chelating with the protoporphyrin, and that enzyme is very simple, ferrochelatase. Okay. Next important point is ferrochelatase is also inhibited by lead. Okay. So in lead poisoning, what is also accumulating? So in lead poisoning, protoporphyrin is also accumulating because lead can inhibit ferrochelatase as well. Okay. Now, that is one thing that you should know. Then another disorder which is associated with the defect in ferrochelatase is EPP. EPP is erythropoietic protoporphyria. Erythropoietic protoporphyria. So erythropoietic protoporphyria, one very important thing is, this is the most common porphyria in children. Most common porphyria in children. Number 2, this is autosomal recessive. autosomal recessive. Then another very important difference in erythropoietic protoporphyria when we compare it with other photosensitivity is this is a non-blistering photosensitivity. So this is photosensitivity is there, but here it is not blisters. Usually photosensitivity is blisters. Here there is no blisters. It is non-blistering photosensitivity where they have skin swelling and eczemas. Okay, so that is erythropoietic protoporphyria, which is autosomal recessive condition. And this is the most common porphyria in children. Okay, so these are the porphyrias. You need not learn heme synthesis. Just know the porphyrias and the enzymes. That itself is enough. Okay, so this is how heme is being synthesized. Now, coming to another very important. Usually, inborn errors of metabolisms are autosomal recessive. But porphyria is an exception. Porphyrias are usually autosomal dominant. Exceptions are there. Now you can tell me which are the exceptions. നമ്മൾ already പഠിച്ചു. പറയൂ വേഗം പറയൂ. ധ്രുവ് ഇല്ലേ? ധ്രുവ് ഞാൻ കാണുന്നില്ല ഇവിടെ. അയ്യോ, നമ്മൾ പഠിച്ചതാ മക്കളെ, പറയൂ. We have learned it. Say fast. ബ്രേക്ക് തരാം പറഞ്ഞാല്.
Congenital erythropoietic porphyria.
ഓക്കെ, കൺജനറ്റൽ എറിത്രോപോയിറ്റിക് പോർഫേരിയ. പിന്നെ നമ്മൾ ഫസ്റ്റ് പറഞ്ഞില്ലേ എന്തോന്ന്?
X-linked protoporphyria.
എക്സ്-ലിങ്ക്ഡ് പ്രോട്ടോപോർഫേരിയ. ഓക്കെ,
Erythropoietic protoporphyria.
ചിൽഡ്രൻ ഉണ്ടാവുന്നു പറഞ്ഞു കഴിഞ്ഞത് എറിത്രോപോയിറ്റിക് പ്രോട്ടോപോർഫേരിയ.
Dehydrogenase enzyme.
ADP, dehydrates deficient porphyria. Okay. So all porphyria except X-linked protoporphyria, AL dehydratase deficient porphyria, then congenital erythropoietic porphyria and erythropoietic protoporphyria. With the exceptions of these four, all others are autosomal dominant. Okay, so that is about porphyria. Now I'm going to tell you what are the most important thing that you have to concentrate when you are learning porphyria. എല്ലാം കൂടെ അവിയൽ പോലെ പഠിക്കേണ്ട ആവശ്യമില്ല. So I will tell you what are the important topics that you have to concentrate on. So, okay. So now after everything, after the class and all, when you are learning, first learning, please do learn everything. Please do read everything. Okay. Now what you should, you have to write it in your revision notebook or towards the 20th notebook if you are making, or what you have to highlight in the same notebook, that is, this is highlighters. I will say the first initial things you just leave. So all these things I have told you as characteristics, you can just leave. Just learn this name, Sorit band. The rest is for understanding. Once you have understood it, you need not learn it again and again. Okay. Then it causes photosensitivity. Just understand that. It's very important. Only porphyrins can cause photosensitivity. Then this is very important. Not in mature RBCs, erythroid precursors and liver. That is a site. Cytoplasm and mitochondria, just remember about our hug. So hug is what you can remember that to learn cytoplasm plus mitochondria. Okay. Now in the porphyria, previous year question wise, I will tell this is a previous year question. B6 deficiency can cause sideroblastic anemia. Plus one more thing that you have to learn, that is a linker to pharmacology I am saying is isoniazid. That is, INH. INH is a treatment for tuberculosis. So if you are giving INH, it causes B6 it reduces the availability of B6. So they are prone to develop anemia. Okay, so it causes B6, reduces B6 availability. That is why whenever we are giving ATT packet, it is like a combined therapy that we are giving, multi-drug therapy. So if we usually give one vitamin along with it. What is that vitamin?
B6.
B6. Why? Because it is affecting, or it is reducing the availability of B6, which is affecting ALA synthase. Okay. So in that way, you need to learn that. Then lead poisoning. It is not ADP that you have to learn here. What you have to learn here is the lead poisoning. Then very, very important, acute intermittent porphyria. You can get a scenario based on acute intermittent porphyria. So please do learn the name of these enzymes as well. Then coming to congenital erythropoietic porphyria, Q-bankilakka ningalkku കാണാം questions on congenital erythropoietic porphyria. But previous year questions, if you search, you cannot find any question on CEP. പക്ഷേ വിടണ്ട, just understand congenital erythropoietic porphyria, brownish discoloration, erythrodontia, etc. Then porphyria cutaneous tarda, this can be a question because this is the most common porphyria. So in that itself says that this is must learn. Porphyria cutaneous tarda. Then you can leave all these things. Erythropoietic protoporphyria also you can leave. Just previous year question wise, it was not asked. Okay. So that is about porphyria. I hope that is clear to you. Now I will give you a 3 minutes. 3 minutes to rest. Then we will continue with the heme catabolism. ആരും വിട്ടു പോവില്ലേ? 3 minutes. Okay, come back. So we'll take a very small topic, heme catabolism. Okay, I will share these notes. If you're not able to write everything in like along with this, I'll share these notes to Sri Lekha. Okay, so shall we proceed? എനിക്ക് ചാറ്റ് കാണാം അപ്പോൾ. Okay. Okay. Yeah, okay. Yes. You want to share something? Any stories or anything? All fine? തെരേസ എവിടെ? ഞാൻ കുറച്ച് പേരുടെ പേരൊക്കെ പഠിച്ചിട്ടാ വന്നത്. നിവേദിത ഉണ്ടോ?
Yes, ma'am.
ആ സാംസങ് എസ്. ഓക്കെ ഓക്കെ. താങ്ക് യു ഫോർ ദ ചോക്ലേറ്റ്.
Okay.
നിവേദിത ആണെന്ന് തോന്നുന്നു എനിക്ക് തന്ന. ഐ എം നോട്ട് ഷുവർ. എനിക്കൊരു ചോക്ലേറ്റ് കൊണ്ട് തന്ന. നമ്മുടെ തെലങ്കാനൈറ്റ്സ് എന്തിയെ? വേർ ഇസ് മൈ തെലങ്കാനൈറ്റ്സ്?
Hi, ma'am.
ഹായ് നവജീവൻ. ഓക്കെ ഓക്കെ.
Hello,
നവജീവൻ.
ma'am.
ഹായ്. റൈറ്റ്. ഓക്കെ. Navjeevan. Okay, so both are attending together?
No, ma'am.
No? Okay. So
No, ma'am.
fine. Okay, so that is about heme. We are learning about heme catabolism. Just നിങ്ങൾ notes അത് എടുത്തു. I hope that you have taken it in the notes as well. Right? Okay. So heme catabolism, it takes place in 3 organ system. So the first organ system is reticuloendothelial system. Okay, that is reticuloendothelial system. In the reticuloendothelial system, what is being formed? Bilirubin is being formed. Bilirubin is being formed in the reticuloendothelial system. So there are a few questions that you can get here. What is the first enzyme here? This enzyme is heme oxygenase. This is a type of monooxygenase. So heme oxygenase is the enzyme, and this enzyme is otherwise called microsomal heme oxygenase because this reaction is taking place inside the smooth endoplasmic reticulum. Okay. The question that you can get here is, what are the products of heme catabolism? So this microsomal heme oxygenase system has a very important product being formed. Please do learn it. Very, very important. Usually in metabolism, I used to say that don't learn, but this is something different. So this produces carbon monoxide. And this is the only endogenous source of carbon monoxide. Only endogenous source of carbon monoxide. And if that carbon monoxide is not going to cause any poisoning here, it's very minimal amount only. So carbon monoxide this is the only endogenous source of carbon monoxide. It will be exhaled. So carbon monoxide, this is the only endogenous source of carbon monoxide. Very, very important. Plus, what is being discarded is Fe2 plus. Iron is being discarded. So from this iron, later on it can form Fe3 plus as well. So why I'm saying Fe3 plus is, one of the exam question was like this. The products of heme catabolism are all except. One option was carbon monoxide. If you know carbon monoxide is produced here, you know that. Second was Fe3 plus. The third option is biliverdin. The fourth option is ALA. What is the answer here? Which are all the following are products of heme catabolism except is the question. So I repeat, biliverdin, Fe3 plus, carbon monoxide, ALA. What is the answer?
ALA, ma'am.
ALA. So don't that is why I have given here Fe3 plus was the doubt asked by many of the students. So Fe3 plus, it is actually Fe2 plus, but this Fe2 plus is converted to Fe3 plus. So the answer is definitely ALA. Okay. Now biliverdin is converted to bilirubin by the enzyme biliverdin reductase. Biliverdin reductase. That name is not so important to learn. Okay, so that is how bilirubin is formed. Now, bilirubin cannot be transported in the blood like that because it is not soluble. So, this bilirubin has to combine with the transporter. Who is the transporter here? It is binding with albumin. So, this albumin bound bilirubin, this albumin is actually having two binding sites for bilirubin. So, one bilirubin here, another bilirubin here. One is a high affinity site, the other is a low affinity site. Not so important. It's important. Pharmacologically, it is important. So bilirubin, because there are certain drugs which can eliminate this bilirubin from this albumin binding sites. So that is causing aggravation of unconjugated hyperbilirubinemia. That is different thing. That is in pharmacology. You might have learned some drugs which eliminate bilirubin from the albumin binding site. That is linked to pharmacology, which you can learn it later. So here what you should learn is bilirubin is combining with albumin and it is going to the next organ system. What is the second organ system here? Liver. Okay, so the second organ system is liver. In the liver, what happens? Just like any guest come to a home, what we'll do first, we'll receive, Indian culture is Aditi Devo Bhava. So we will receive our guest. Okay, so first thing is we are going to receive. Just like that, this liver is going to receive this guest that is called bilirubin. So that is the first step is uptake. Now, when it is taken into the liver, it has all the chance to go out as well. So for that sake, this bilirubin is bound with ligandin Y. Okay, ligandin Y, which is a bilirubin binding protein. So this bilirubin binding protein will bind this bilirubin inside the liver itself. Now in the liver, what happens? So it is some guest coming to a home. The next thing that we'll do is we'll give some coffee or tea or at least some water to drink to the guest. So like that, this bilirubin is being conjugated. So the second step is conjugation. So this conjugation is by combining with whom? It is conjugated by whom? Glucuronic acid. Glucuronic acid. And what is that enzyme called as? That enzyme is called UDP, glucuronyl transferase. So UGT1 and 2, two isoforms are there, UGT1 and 2. So that is UDP, glucuronyl transferase, which is transferring a glucuronic acid to bilirubin so that it forms bilirubin monoglucuronide and bilirubin diglucuronide. Okay, so the second step is conjugation. And remember, liver has immense conjugation capacity. The next step is the most crucial step. So whenever a guest come to our home, also the most difficult step for us is to get rid of this guest so that we can have a house, we can enjoy in our house, because if the guest is there, there is always restriction. So the third important thing that we should do is we should get rid of them, right? And that is a most difficult step also. So likewise, in the entire heme catabolism process, the rate limiting step is this extrusion or expulsion of this conjugated bilirubin out of the liver. Okay. So the third step is called as secretion. It is an active process. It's an active process which require some proteins which is called as MOAT1. What is MOAT1? Multi-specific organic anion transporter. So it is an active process using this transporter protein. So that is the rate limiting step of the entire heme catabolic process. This is the rate limiting step, secretion of conjugated bilirubin. So this is what happens inside the liver. Now it is secreted, it is going through some, what is that route? It is the common bile duct. So the bile is containing this bilirubin. So this is called as the bile pigment. So that bilirubin which is excreted is the bile pigment. So which means the bile that is secreted here contains bile pigment plus something else. Tell me. Bile has bile pigment plus. Bile pigment is nothing but
Salts.
bilirubin. Yes. Plus bile salt. Okay, so bile pigment plus bile salt is one being excreted through the bile and it reaches the intestine. Now, once it reaches the intestine, then there are lots, millions and millions of bacteria inside the intestine which take care of this BDG. Can you tell me what is this BDG? What is BDG? B എന്തായിരിക്കും? What will be B? Navajeevan,
Bilirubin diglucuronide.
diglucuronide. Yes, yes, that is it. Bilirubin diglucuronide. Bilirubin mono is also there. Mostly both are there, but I have written here bilirubin diglucuronide means that this is the conjugated bilirubin. Now, conjugated bilirubin plus bile salt is inside the intestine. We are not considering about the bile salt. We know it is excreted. Now, what happens to this bilirubin diglucuronide? It is taken care of by this bacterial enzymes, which is called as beta glucuronidase. Beta glucuronidase is the enzyme which is deconjugating this bilirubin and it is converted to another compound which is called urobilinogen. Remember, porphobilinogen is in heme synthesis, urobilinogen is in heme catabolism. Don't forget that. So urobilinogen is synthesized and most of them is synthesized in the ileum. Okay. Now, once the urobilinogen is synthesized, what will happen? 80% of urobilinogen is excreted. %80 is excreted as SBG. What is SBG? Stercobilinogen, and this is later on converted to SB. So that is stercobilinogen and its active form stercobilin. And this is the one which is giving color to feces. Okay. So that is the most important fate. But during this, so most of them is excreted, but entire of this is not excreted. So some of it is undergoing a circulation, and that is called as around 20% is undergoing the circulation, which is enterohepatic circulation. If you remember bile salt, 98 to 99% is undergoing enterohepatic circulation. But at the same time, this bilirubin is not undergoing, or the urobilinogen which is synthesized from bilirubin is not undergoing, majority is not undergoing enterohepatic circulation, majority is excreted, 20% is undergoing enterohepatic circulation. So during this enterohepatic circulation, there are some portosystemic shunt. Through some shunt, what will happen? Some of the urobilinogen will reach the systemic circulation. So from the systemic circulation, it can come to the kidneys. So that is being excreted, which means urobilinogen is excreted in urine. But it is not a huge quantity. It is only traces. Traces of urobilinogen is excreted through urine. Okay. So this is what is called as the heme catabolism. I think this is very simple to you. So I'm not explaining it once more. Now we are coming to what is called as the jaundice. So what are the fates of urobilinogen? Can anybody tell me? Karun Ajmal. Karun Ajmal. Is that the Karun that I have called from that class? Karun? Karun Ajmal എങ്ങനെ വന്നേ? Karun and Ajmal. Karun പോയാ? അജ്മൽ നീ എന്നോട് പിണങ്ങി പോയോ? കരുൺ, ഞാൻ എന്തായാലും കരുണിനെ വിളിക്കൂന്ന് വിചാരിച്ചു തന്നെ വന്നതാ, എന്നിട്ട് കരുൺ എന്നെ ഇട്ടേച്ചു പോയി. ഐ എം സാഡ്. ഞാൻ അന്വേഷിച്ചു എന്ന് പറ കേട്ടോ കരുണിനോട്. ഞാൻ ശ്രീലേഖയോട് പറഞ്ഞോളാം, അല്ല ഞാൻ റമീസിനോട് പറയും കരുണിനെ അജ്മലിനെ അന്വേഷിക്കണമെന്ന്. ക്ലാസ്സിൽ കയറാത്ത രണ്ട് കക്ഷികൾ ഓണാക്കിയിട്ടേച്ച് പോയിക്കുന്നത്. കരുൺ. Okay, fine. So what are the three fates of urobilinogen? Can anybody tell me? Nivu, tell me. Three fates of urobilinogen. Fast. We need to finish the class. Techno. Yes, 80% as SBG, 20% undergo enterohepatic circulation, traces excreted as urine. Okay, very good, very good. Okay. So somebody is there here listening. Okay, fine. Next, we are going to the three types of jaundice. You have to tell me what will happen to this different LFT parameters. The first one is total bilirubin. Whether it is hemolytic or hepatic or obstructive, only if you tell me, I will mark here, okay? So what will happen to total bilirubin? Who will say the answer? You can put it in the chat box. What will happen to the total bill? Okay, so definitely it will increase. Okay, so there is no doubt all this is increasing. irrespective of what is the type of jaundice. Now, what is direct bilirubin? Direct bilirubin is conjugated or unconjugated. Who will type? What is direct? Yes, direct is conjugated. Indirect is unconjugated. How can we learn this? Vowels together, consonants together. Vowels together, consonants together. So direct is direct and conjugated. I and U. So they are vowels together. That's how you can remember. Okay. Now you have to be very careful. So if it is hemolytic jaundice, then what type of bilirubin is elevated? Just put it in the chat box first. Yes. So if it is hemolytic jaundice, we know unconjugated bilirubin is elevated. What about direct? It is usually normal or slightly elevated also, it's fine. Borderline high. It will be borderline high or it is normal, I'm writing. Now going to obstructive jaundice. Hepatic jaundice, we'll keep it there. So what in obstructive jaundice, which fraction is elevated? Who will put it in the chat box? Let me see. Leah, Srivisha. Okay, right. So obstructive, that means it is conjugated, that is elevated. That is direct or indirect? Conjugated is direct or indirect? Okay. So conjugated is increased, whereas the unconjugated is normal here. Now tell me about the bile salt, bile pigment. Bile salt, bile pigment means they are the components of bile. That is present, remember it like this, when there is obstruction to the bile flow. It's a simple thing to remember. Whenever there is obstruction to the bile salt, whatever is present in the bile is present in urine. This is what you have to remember. Okay. So bile salt and bile pigment is positive in what type of jaundice? Yes, obstructive. Yes. So it is positive in obstructive jaundice. Okay. What is the test for bile salt? Sometimes the test name can be given to you. What's the name of bile salt? Hayes test. Okay. What's the name for bile pigment?
Checks.
Pauschet's test. Okay, good. Next is the urobilinogen. What will happen to urobilinogen in obstructive jaundice? Will it be present or absent? This is obstruction. Obstruction means here there is a block. So will urobilinogen be produced or not? If there is obstruction, no. Yes, so it is absent. Now we'll come to the hemolytic jaundice. In hemolytic jaundice, there is no obstruction to the bile flow. So these are negative. Bile salt, bile pigment negative. Then what about urobilinogen? Urobilinogen is highly positive. Why? Because excess heme catabolism, excess conjugation, excess conjugated bilirubin reaching the intestine. So excess urobilinogen is produced. So it is highly positive. Okay. Then hepatic is like mixed. So it is always both are elevated. Direct and indirect is elevated. This is plus or minus, plus or minus, plus or minus. So that is about the hemolytic as well as the hepatic and obstructive jaundice. What is the enzyme marker of hepatic jaundice? Here, ALT, AST. AST and ALT is elevated in hepatic jaundice. Obstructive jaundice, this is very commonly asked. One is ALP. ALP is alkaline phosphatase. The second is gamma glutamyl transferase. And the third one is 5' nucleotidase. These are the enzyme markers for obstructive jaundice. Previous year question wise, this can be asked. This is also asked. Gamma glutamyl. Last NEET also the same. Gamma glutamyl transferase or transpeptidase is elevated in obstructive jaundice. Hemolytic jaundice doesn't have any marker, but LDH you can say, because LDH is present in the, lactate dehydrogenase is the enzyme which convert pyruvate to lactate, which is present in the RBC. So that is one enzyme you can say. There is not much enzyme for hemolytic jaundice. LDH you can say LDH, but it is not a specific enzyme for RBC alone. Okay, so these are the enzyme markers. So we have completed heme catabolism as well. So it's a very, very important topic. I'm not saying this is important, that is important. Everything is important in the case of heme catabolism. Even if you forget entire thing about the heme catabolic pathway, it's fine. But this is very commonly asked, different types of jaundice. Maybe as a part of surgery question or medicine question, it can be asked. So it's a very, very important applied aspect. Heme catabolism, just know overall idea is enough, but remember this, the product of heme catabolism was asked in one of the exam. Okay, so that was heme catabolism. So with that, we finished the heme catabolism. I'll give you a 3 minutes break, and afterwards we are starting phospholipids. That's very, very important. Okay, so now we are starting phospholipids. So first and foremost, what is a phospholipid? Are you all with me? Okay. So phospholipid means it is a compound lipid. Compound lipid always means it has a lipid plus a non-lipid component in it. That is a phosphate group. Like lipoprotein. Lipoprotein means it has lipid as well as protein. So just like that, phospholipids are a group of compound lipids. So that's the first thing. There are two types of phospholipids. One is something which is having glycerol as a backbone. Okay. So it is having glycerol as a backbone. Number two is something which is having a kind of alcohol which is called sphingosine as the backbone. So we have two types. That is, one is glycerophospholipid. The second is sphingophospholipid. So glycerophospholipid means it has glycerol as its backbone. Sphingophospholipid means it is having sphingosine as its backbone. Okay. So I'm writing one name here. Glycerol is the hero here. Sphingosine is a major component in the case of sphingophospholipid. Okay, now we are going to see what is the general structure of these two. So first we will see what is a glycerophospholipid. So glycerophospholipid means that it has number one, glycerol. Okay, this is attached with the two fatty acid. Now who will tell me what is this? Chat box litadi. You can put it in the chat box. Yes, so that is diacyl glycerol plus phosphate group plus a nitrogenous, usually nitrogenous, non-nitrogenous is also there. So I'm writing here nitrogenous base. So there are four components for every phospholipid. One is glycerol. The second is two fatty acid. That is the fatty acid residue. We call it as acyl. The third is the phosphate group. And the fourth is the nitrogenous base. So diacyl glycerol plus phosphate. Okay. Now we call it as phosphatidic acid. Now, this phosphatidic acid is attached with various nitrogenous base. So, this is the basic component of what is called as glycerophospholipid. Okay. Now, going to the next one, that is sphingophospholipid. Sphingophospholipid has, instead of glycerol, here we have sphingosine plus one fatty acid. Remember, the sphingosine plus fatty acid is what we call as ceramide. These terms you should be knowing. Ceramide. Ceramide means sphingosine plus fatty acid is called ceramide plus a phosphate group plus a nitrogenous base. So these are the components of what is called as sphingophospholipid. So who will tell me what are the components of sphingophospholipid? You can tell me. Unmute ചെയ്തിട്ട് പറയാം. Anita. ഉറങ്ങിപ്പോയോ? Dhruv. Okay, in the chat box, what is sphingophospholipid? What are the 4 components of sphingophospholipid? Sphingosine plus fatty acid plus, yes, phosphate plus nitrogenous base. Good. Okay, good. So that is sphingophospholipid. Okay, that concept should be clear. That is what I want. Right, very good. 1 plus JK, everything. Hats off. Thank you. Okay, so now we are going to see various glycerophospholipids. Okay, so starting with the, oh my God, ceramide plus NB, right? Ceramide plus NB plus a phosphate group is also there. iPad plus phosphate group. Okay. So we are starting with phosphatidic acid, which is the basic glycerophospholipid. It is very easy to understand now. Okay, glycerol plus 2 fatty acid plus phosphate. That is called diacylglycerol plus a phosphate group is what is called as phosphatidic acid. Very simple. Where is it present? This is usually present in the cell membrane. Most of the phospholipids are present in the cell membrane. This is present in the cell membrane. Okay. Then lecithin. Lecithin is... Now I will write the components. You have to tell me the name. Okay. Challenge ആയിക്കോട്ടെ ആരാണ് ആദ്യം ചാറ്റിൽ ഇടുക നോക്കട്ടെ. So I'm going to tell you the components. Glycerol, നോക്കട്ടെ ആർക്കാണ് പോകുന്നത്. Very good. So up to this is phosphatidic acid, right? Up to this is phosphatidic acid plus choline. ആരാണ് ആദ്യം ഇട്ടത്? യെസ്, ആർ ജോർജ്. ആർ ജോർജ് ഓക്കെ. ആർ ജോർജ് ആരാണെന്ന് എനിക്ക് ഫുൾ നെയിം അറിയില്ല. ബട്ട് എനിവേ എല്ലാത്തിലും ആൻസർ പറയുന്ന ഒരാളാണ്. റോബിൻ ജോർജ് ആണോ റിയ ജോർജ് ആണോ എന്ത് പേരാന്ന് എനിക്കറിയില്ല. ഓക്കെ, സോ ഗുഡ്. Okay, so that is phosphatidyl choline. Now I'll ask you one more thing. You have to expand this, okay? Lecithin, we usually call, it is a lung surfactant. So as a lung surfactant, we'll give another name. I will write the short form here. Who will write this expanded form? ആദ്യം നോക്കട്ടെ. DPPC. Yes. Okay, Akhil Raj. Good. Right. Okay, so that is Akhil. Good. Okay, so it is dipalmitoyl phosphatidylcholine. Now let me ask you this question. Why it is dipalmitoyl? What is that palmitoyl standing for? Yes, very good. Zoom user. I don't know your name, but still, anyway, you answered it right. Good. So these are the 2 fatty acids. The most common fatty acid, that is, yes, palmitoyl. Yes. So it is the most common fatty acid that is present in lecithin. Okay. Now I think that is clear to you. Lecithin is dipalmitoyl phosphatidylcholine. Okay. Or we can just say it as phosphatidylcholine. And you all know this is the most abundant phospholipid in cell membrane. This is the most abundant lung surfactant. Then this is the storehouse of choline. Why choline is very important in our body? Choline function എന്തൊക്കെയാണ്? വളരെ important function that you learn in physiology. Yes, neurotransmitter. Yes, acetylcholine. Yes, acetylcholine, which is neuromuscular junction. You know the importance of choline. So it is always a store. Yes, very good. So it is a storehouse of choline. Okay. Next is cephalin. What is cephalin? Cephalin is Again, I'm going to write, okay? Glycerol. Let me see who will answer this. Right? What is this? Vega, Vega, Vega. Aranad. Yes. Correct. Jamil. Right. Now you got it. Okay, right. All of you. So that is called as phosphatidyl ethanolamine. Okay, phosphatidyl. So this is phosphatidic acid plus ethanolamine. So where can you find cephalin? Cephalin is also present in the cell membrane. Okay. Now, phosphatidyl inositol. Inositol, usually we know that it is present in the inner leaflet of plasma membrane. You know, plasma membrane has an outer leaflet, outer and inner. So in the inner leaflet, you can find phosphatidyl inositol as usually, you know, PIP2. Phosphatidyl inositol diphosphate. So from PIP2 is what we get diacyl glycerol plus, can anybody fill this? ആർക്കെല്ലാം അത് fill ചെയ്യാമോ? Yes. IP3. So that is inositol triphosphate. So one phosphate is coming from here. We know that there is a phosphate here. So with that next is inositol diphosphate combines with that phosphate already present, become inositol triphosphate. So what is the importance of this? Where can we find this? It is a second messenger in hormonal pathways. Second messenger in hormonal pathways. Okay, that is what you have to learn. Phosphatidyl serine means phosphatidic acid plus serine. That is usually important in apoptosis. Okay. Now, I'm coming to a very important phospholipid. Don't forget this. It's a previous year question as well. It is diphosphatidylglycerol. Which means a glycerol, you just understand it like this. It is a glycerol, okay, which is sandwiched between two phosphatidic acid. So there is a phosphatidic acid here. There is a phosphatidic acid here, another phosphatidic acid, and in the middle part, you can find glycerol. So that is what is called as diphosphatidylglycerol. glycerol. It is otherwise cardiolipin. Why it got the name cardiolipin? Because this is first isolated from cardiac muscle. First isolated from cardiac muscle. And it is present in the inner mitochondrial membrane. It is present in inner mitochondrial membrane. It has a very peculiar characteristic. That is, this is the only phospholipid with antigenic properties. Antigenic properties, which means this cross react with antibodies of Treponema pallidum, which means it is giving false positive test for what? Who will answer? Yes, syphilis. Yes. So it is antigenic property, so it gives false positive test for syphilis. So that is cardiolipin. And this, what was asked in the last exam is a patient presented with muscle weakness and cardiomyopathy. Okay. And this disorder is associated with a phospholipid. So which is that phospholipid? So as we have already discussing cardiolipin, you understood what is a phospholipid, right? So now my question is not which phospholipid. The question is what is this disorder called as? Who will tell me? Last need, this was a question. Yes, that is called Barth syndrome. Barth syndrome. Yes, very good, very good. Barth syndrome. This is otherwise called as cardioskeletal myopathy. So it can explain cardioskeletal myopathy. Okay. Now this cardiolipin is also associated with aging, hypothyroidism, heart failure. Okay, all these are there, but previous year question wise, what was asked is this one, Barth syndrome, cardioskeletal myopathy. Okay. So this is a previous year question. Okay, that is why I told you this is very important. So if that much is clear, we are moving on to sphingophospholipid. Means who is the backbone of sphingophospholipid? Chat box. Who is the backbone of sphingophospholipid? Yes, sphingosine is the backbone. Okay. So only one sphingophospholipid is there. That is sphingomyelin. Sphingomyelin. It consists of ആർക്ക് പറയാം what is it consisting of? Short ആയിട്ട് എഴുതിയാൽ മതി. It consists of 4 components. One is clear to you. One is അയ്യോ പോയോ എല്ലാവരും? Come on, my smart boys and girls. Sphingosine plus fat. Yes, palmitic acid, serine ഒക്കെ ഉണ്ട്. That is sphingosine is consisting of palmitic acid and serine. What you said is right. Sphingosine plus fatty acid. And what is that called as? Sphingosine plus fatty acid is called as? Yes, ceramide plus phosphate plus the nitrogenous base here is choline. Okay, so this is the component, or these are the components of sphingomyelin. And where is this sphingomyelin present? Sphingomyelin is present in the myelin sheath. It is present in the white matter of brain. White matter of brain, and then in the cell membrane. Also in as a lung surfactant. We know about LS ratio. LS ratio, that stands for sphingomyelin. Okay. So these are the various places where sphingomyelin is present. Right. Okay. So we have seen what is sphingomyelin. Now I'm going to another group, okay? I'm jumping from this group to another. But when I'm jumping from this group to the next group, I'm taking something from behind. So I'm going to take sphingosine with me, but I'm leaving behind the phosphate group. So phosphate group, I'm just leaving behind and I'm going to the next group. So this group is called as glycolipids or glycosphingolipids. So tell me, what is glycolipids? Phospholipid means phosphate plus lipids. What is glycolipids? That name is telling you something. What does that glyco stands for? Come on, ഉറങ്ങിപ്പോയോ എല്ലാരും? What is that glyco stands for? Okay. Glycogen, okay. It's not glycogen exactly, but carbohydrate. Okay, okay. Okay, it can be glucose, it can be anything. So generally, this is a carbohydrate plus lipid. Okay. So we are going to compare sphingophospholipid and glycosphingolipid. Sphingophospholipid means phosphate group is present. We have seen that, right? Now, glycosphingolipid is phosphate group present. No, there is no phosphate here. Sphingosine, it is present, both, which means glycosphingolipid is a group where sphingosine is present, but there is no phosphate group. Okay. Just understand that. That is enough. Now, there are three types of glycosphingolipids. That name also, we'll just very fast we'll go. Cerebroside, globoside, ganglioside. Just understand what is cerebroside. Cerebroside means, I'm going to write something. You have to tell me what is this, okay? Let me see who will write it first. Sphingosine plus fatty acid plus monosaccharide. I'll give you two names. This monosaccharide can be glucose. This monosaccharide can be galactose. So what you have to tell me is, what is this? Or what is this sphingosine plus fatty acid? Tell me that. Yes, ceramide. Okay. So what is this? Ceramide plus a glucose. So that is what we call as glucocerebroside. And this is galactocerebroside. Now I'll tell you something about this. That is, glucocerebroside is present in the extraneural tissues. Extraneural tissues, whereas galactocerebroside is present in the neural tissues. Extraneural and neural. I will ask about this later. Now, who will tell me? I'm asking you, where is galactocerebroside present, neural or extraneural? Yes, galactocerebroside is neural, whereas glucocerebroside is extraneural. Okay. Yes, correct. Next, we go to what is globoside. Just even if you don't learn it, it's fine. Globoside means ceramide plus an oligosaccharide. Okay, ceramide plus an oligosaccharide. Ganglioside is what we write as GM1, GM2, etc. Ganglioside means ceramide plus oligosaccharide plus one thing more you can find there is NaNA. What is NaNA? What is NaNA? Let me see. N-acetyl neuraminic acid. Okay, so that is Na. So whenever there is NaNA, then we call it as ganglioside. That is what we write as GM1, GM2, etc. Just understand. That is enough. Okay. So what I said is glycolipids or glycosphingolipid means it is a carbohydrate attached to the lipids. Right? Then if it is only one monosaccharide, we call it as cerebroside. If it's a disaccharide or an oligosaccharide, we call it as a globoside. If that disaccharide or an oligosaccharide residue is having an acetylneuramic acid, we call it as ganglioside. Okay. Now we are going to, now what we are going to learn is what you have to learn. That is sphingolipidosis. So what is sphingolipidosis? degradation of sphingosine-containing compounds take place inside an organelle, and that is called lysosome. So, defect in the degradation of the sphingosine-containing compound takes place inside the lysosomes. So, any defect in its degradation is called as sphingolipidosis. Okay, it includes the sphingomyelin as well as the glycosphingolipids we have learned. So, any sphingosine containing compounds, degradation takes place in the lysosome, and hence it is a LSD. What is LSD? What is LSD? Yes, correct. LSD is, yes, lysosomal storage disorder. Okay. So we are going to learn a list of lysosomal storage disorder. Okay. Be very attentive. Okay. The first one. First one, we are starting with the GM1 gangliosidosis. Just learn the name of the enzyme. No need to learn, I will just tell you how to differentiate between these two. Only the differentiating feature you need to learn. So the first one is GM1 gangliosidosis. It is the one which convert GM1 ganglioside to GM2 ganglioside. No need to learn this reaction, okay? No need to learn. Learn this enzyme only, beta galactosidase. This is the only thing that you have to learn. GM1 gangliosidosis. The enzyme defect is, I'll ask you later. So beta galactosidase. So what will accumulate here? GM1 ganglioside accumulate, and hence it is called as GM1 gangliosidosis. Okay. So they usually present with a very characteristic features like low set ears, long philtrum. Okay, these are some of the, and angiokeratoma. I'm highlighting something here. I will ask, there are only two disorder where angiokeratoma is there. Only two disorder. This is one. Okay, note that point. Angiokeratoma is present in GM1 gangliosidosis. So, rest, what are the general features? I'll tell you in the last. From there itself, you can understand. So, GM1 gangliosidosis, I'm saying, what are the two important parts that is coming to your mind? Just comment. Only two things you need to learn. GM1 gangliosidosis. Angiokeratoma, good. Number two, enzyme. Yes, beta galactosidase, angiokeratoma. No need to learn anything else. Two things, angiokeratoma, beta galactosidase, nothing else. Next we go to, I will come back to this. All these things together, I'll summarize. So GM2. GM2 means the GM2 ganglioside is converted to GM3, and that is by an enzyme hexosaminidase. There are two isoforms, A and B. Okay. So if I say GM2, you won't understand anything. But there are two GM2 gangliosidosis. That two names you are familiar with. So the first one is Tay-Sachs disease. Tay-Sachs disease. So in Tay-Sachs disease, the enzyme defect is hexosaminidase A only, A isoform only. And one very important thing I'm going to say about Tay-Sachs is no visceromegaly. No visceromegaly. Rest all the common features are there, but this is very characteristic, no visceromegaly. Number two is Sandoff's disease. Here the defect is hexosaminidase A and B. Both are defective. Here hepatosplenomegaly plus or minus. Plus hepatosplenomegaly is there. Then how to differentiate it from Tay-Sachs? Most of the students ask me this doubt. The next differentiating feature that is given in Nelson, according to Nelson, is it is cardiac abnormalities is also seen in Sandoff's disease. Okay, so this is what, visceromegaly absent in Tay-Sachs, but in the case of Sandoff's, it can be plus or minus. Okay, so this is how we differentiate. Okay, now if I'm saying GM2 gangliosidosis, only 3 points should come to your mind. What are the 3 points? First, the name. Write the name. Yes, the name is name. Yes, hexosaminidase A and B. Tay-Sachs, Sandoz, the name. Name include എല്ലാ നെയിമും കൂടെ ഒരുമിച്ചാണ് ഞാൻ സെക്കൻഡ് പോയിന്റ് പറഞ്ഞത്. Tay-Sachs, Sandoz, hexosaminidase A in Tay-Sachs, but in Sandoz it is A and B. Okay. Then what you have to learn is no visceromegaly. Yes, Tay-Sachs, no visceromegaly. Angiokeratoma, if I'm saying what disorder should come to your mind? Angiokeratoma പറഞ്ഞാൽ which name? GM1. Okay, right. Right. Now we go to Krabs disease or Krebs disease. So here the defect is beta galactosidase. Hey, I have already told you beta galactosidase. Again, I'm saying beta galactosidase. It is because this actually the name of this enzyme is galactocerebrosidase. Galactocerebrosidase. So this name is, this is an enzyme which convert galactocerebroside to ceramide. So the defect is here. So here what is accumulating is galactocerebroside. So that is why it is removing a galactose residue. Hence it is called galactosidase. But actually speaking, it is not the correct name is not galactosidase. It is galactocerebrosidase. Galactocerebrosidase. Now, what I said about galactocerebroside, where is it present? Neural or extraneural?
Neural.
Neural, very good. Neural, Medicker. Good. So neural, which means in Krebs disease, there is severe neurological deficit. Very easy to remember. Then it is having some inclusion bodies. That name of the inclusion body you just learned, it is globoid cell inclusion. Okay. Then, will there be any visceromegaly? Yes or no? No. Yes. So, they are having severe neurological deficit, but there is no visceromegaly. In what? Krebs disease or Krebs disease. Okay. So, if I say, just learn 3 points in Krebs disease, what should come to your mind? Krebs disease, 3 points. Enzyme name is must. Name of enzyme? Galactocerebrosidase. Number 2, where is it present? That will give neural. Yes. So that itself will give you the third point. What is it? Globoid cell inclusion, usually not. Yeah, you can remember. The third point, no visceromegaly. Yes, only 3 points. Only 3 points. Which are the 3 points? Somebody, yeah, no. Somebody can unmute and answer. 3 points. Krebs disease. Enzyme? Galactocerebrosidase. Okay. Then symptom or presenting feature?
Severe neurological deficit.
Neurological. No visceromegaly. Yes. Yes. Okay. Now we go to Gaucher's disease. ഇത് പഠിക്കാതെ പോവില്ല മക്കളെ. There is no there is no exam without Castle's necklace and the crumpled tissue paper appearance. Okay. So Gaucher's disease, you all know why it is very frequently asked. Because of this point that I'm going to say. This is the most common lysosomal storage disorder. That is why it is very commonly asked, Gaucher's disease. Okay, so what is a biochemical defect here? It is glucocerebroside is converted to ceramide. A reaction, no need to learn. Enzyme is beta glucocerebrosidase or beta glucosidase. Beta glucocerebrosidase or beta glucosidase is the enzyme defect here. So what will accumulate here? Glucocerebroside accumulate. Now you tell me, where is glucocerebroside present? Neural or extra? Yes, very good, Technopova. It is extraneural. So what, will there be any mental retardation or neurological deficits? No, yes. Will there be visceromegaly? Yes, there is visceromegaly. There is no neurological symptoms. And one more thing you remember, every sphingolipidosis has this common feature called as cherry red spot. ഞാൻ ഇതുവരെ അതിനെപ്പറ്റി പറഞ്ഞിട്ടില്ല because I don't want to say any common feature. Wherever it is not present, I will tell, which means in others it is present. So cherry red spot is absent in Gaucher's disease. Now in bone marrow, what you can find? Bone marrow. Yes, Gaucher cell. What is the characteristic appearance of Gaucher cells? Crumpled tissue paper appearance. Okay. Then in the X-ray of the lower limb, you can find a characteristic feature which is looking like this flask. This flask is called as Erlenmeyer flask. So that is a deformity, okay? So there is no mental retardation. There is no cherry red spot. The enzyme defect is asked. Everything about Gaucher disease, please do learn. Don't leave anything in Gaucher's disease. ബാക്കി എല്ലാത്തിലും I told you, just learn 1 or 2 points. That is enough. But Gaucher's disease, learn everything. How will you present? How then? Why there is bleeding manifestation here? Why there is bleeding manifestation in Gaucher's disease? Because there is deficiency of one of the blood cell. What is that? As it is infiltrating the bone marrow, yes, platelet. So there is thrombocytopenia, hence there is bleeding manifestation. Pathological fractures, yes, thrombocytopenia, correct. So bleeding manifestation, pain and pathological fractures, especially long bones and massive hepatomegaly and splenomegaly. There is no neurological deficit. There is no cherry red spot. Gaucher cells in bone marrow, Erlenmeyer flask deformity. That is Gaucher's disease. Do learn everything. Okay. So I'm moving to the next one. That is Fabry's disease. Fabry's disease, the biochemical defect is alpha galactosidase. Alpha galactosidase. So if I say beta galactosidase, the two disorder that come to your mind, please put it in the comment chat box. Beta galactosidase. If I say beta, yes, GM1 and Krabs disease. Okay. GM1 and Krabs disease. Okay. This is alpha galactosidase. Alpha galactosidase. If I say beta glucosidase, what should come to your mind? Beta glucosidase. Yes, Gaucher's. Right, right. So Fabry's disease have some peculiarity. It is an X-linked recessive disorder. So which means only males are affected. Okay. Fabry's F ആണെങ്കിലും it is seen in males. Okay. Then there is no mental retardation. There is no cherry red spot. Just like in the case of Gaucher's disease. Now, I'm going to tell you something. Tell me, which are the two disorders? This feature that I have highlighted is there. Yes, very good. GM1, Gaucher and Fabry, no mental retardation, Gaucher and Fabry. What I highlighted is angiokeratoma. Angiokeratoma, If I'm saying angiokeratoma, only two disorders should come to your mind. What are they? Yes. What are they? GM1 and Fabris. Okay, GM1 and Fabris. Okay. If I say no mental retardation, no cherry red spot, two disorders should come to your mind. Which are they? Yes, that is Fabris and GM1. Okay, correct. If I say beta galactosidase, two disorders should come to your mind. Which are they? Yes, GM1 and Krabis. Very good, very good. So these things should be thorough. Now, this Fabris usually are blind. Why they are blind? Because they have lenticular opacity. Lenticular opacity is present and very, 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 very important. What I'm highlighting here. Which are the two disorders where this thing that I have highlighted now is there? ഒരെണ്ണം കൂടെ ഉണ്ട്. 3 ഉണ്ടെന്നാണ് എൻ്റെ ഓർമ്മ. Okay, at least 2 you say. Multi-sclerosis means അയ്യോ എൻ്റെ multi-sclerosis ഇത് എന്തോ പോലെ. Tell me. Yes, babesiosis, nephrotic and മിടുക്കന്മാര്. Good, good. So babesiosis, nephrotic and this one are Fabry's disease. That is having babesiosis. It's a previous year question, okay? Previous year question. Okay, so now we are going to summarize Fabry's. No mental retardation, no cherry red spot, only males are affected. Then they have angiokeratoma and they have multi-sclerosis appearance in the urinary sediment. Okay. Now Farber's important. I'm just giving for completion's sake. Farber's disease, the enzyme defect is ceramidase. Ceramidase, it resembles rheumatoid arthritis. Very difficult to learn everything. So I won't give much importance to Farber's disease. Least importance only for Farber's. Niemann-Pick, very commonly asked, what is the enzyme defect? Niemann-Pick is something which is considered as a prototype of all the features of sphingolipidosis you can find in Niemann's disease, like cherry red spot, then visceromegaly. All these features are there in Niemann-Pick's disease. Okay, what is enzyme defect here? Yes, very good. Yes, very good. Xiaomi. Yeah. I don't know what's his name, his or her name. Very good. It is sphingomyelinase. Sphingomyelinase. Okay. Next is this disorder has a peculiar inclusion body. What is the inclusion body you can find in Niemann-Pick disease? Whenever you go through the road, you can see this. റോട്ടിലെല്ലാം കാണാൻ പറ്റുന്ന ഒരു സാധനമാണിത്. ഹമ്പ്. പിന്നെ ഗട്ടർ പറഞ്ഞില്ലല്ലോ ആരും അല്ലേ? ഗട്ടർ, ഹമ്പ്, കുഴി, മൂള്. Rocks. Okay. Yes, yes, yes. I got the answer. Zebra crossings you can see, right? So, zebra body inclusions is seen in Niemann-Pick disease. Okay. All the classic features of sphingolipidosis with the zebra body inclusions, you can definitely say the answer as Niemann-Pick disease. Enzyme defect, sphingomyelinase. Okay. Then comes to metachromatic leukodystrophy. It's tough, but the enzyme defect is very commonly asked. That is aryl sulfatase A. Aryl sulfatase A. And here there is no visceromegaly. No visceromegaly. Okay. No visceromegaly. So now I'm going to something, a disorder that is called Wolman's disease, which is otherwise called as cholesterol ester storage disorder, cholesterol ester storage disorder. Enzyme defect is acid. It is a lysosomal enzyme. That's why we say acid lipase. Acid lipase. Remember, this is not a sphingolipidosis, but this is a lysosomal storage disorder. Lysosomal storage disorder. This Wolman's disease, they usually has a very pathognomonic feature. The pathognomonic feature in a Wolman's disease is calcification of adrenals. This can be an image-based question to you. Plus, they have relentless vomiting. Relentless vomiting. And they have watery green diarrhea. All these are features of Wolman's disease, watery green diarrhea. So that is about Wolman's disease or Wolman's disease, whatever way you can pronounce. So we have seen many things. I'm going to conclude everything into some general features. This is what you have to learn. All sphingolipidosis are autosomal recessive except, you have to tell me the answer. Yes, very good. No mental retardation in. Gaucher and Fabris. Okay. Gaucher's Fabris. ഇതിനൊക്കെ ആർക്കെങ്കിലും ഒരു നിമോണിക് കണ്ടുപിടിക്കാമെങ്കിൽ എനിക്ക് കണ്ടുപിടിച്ച് തരാം കേട്ടോ. നോ മെന്റൽ റിട്ടാർഡേഷൻ ഇൻ ഗോച്ചേഴ്സ് ആൻഡ് ഫാബ്രിസ്. നോ ചെറി റെഡ് സ്പോട്ട് ഇൻ. യെസ്, അഗെയിൻ ഗോച്ചേഴ്സ് ആൻഡ് ഫാബ്രിസ്. Now what I'm going to write is no visceromegaly. Come on. No visceromegaly. My girlfriend has no mental retardation. Wow, super. Good. So who is your girlfriend? Yes, give a good clap. That's good. What's the name? Ars. My girlfriend has no mental retardation, and you just say cherry red. There is no cherry red spot. So can you correlate with that also and say one mnemonic ആർക്കെങ്കിലും വേറെ എന്തെങ്കിലും ഓർമ്മ വരുന്നുണ്ടോ? Yes. My girlfriend has no mental retardation. Very good. ഇതിന്റെ കൂട്ടത്തിൽ ചെറി റെഡ് സ്പോട്ടിനെയും കൂടെ കയറ്റിക്കേ. Ars 57. ഓക്കെ, എത്ര കയ്യടിയാ നിനക്ക് കിട്ടിയേ. ഗ്രേറ്റ്. Okay. അതിന്റെ കൂട്ടത്തിൽ വേറെ ഒന്നും കൂടെ കേട്ടണം. Along with that, you just add. Yes. Great. Oh, she hates cherry. Only my girlfriend has no mental retardation. But no. Oh, okay. No cherry lips, only dimple. Great. No cherry lips. Okay. That is good. Okay, so I'm choosing one, okay? I'm choosing one. That cherry lips പറഞ്ഞ ആരായിരുന്നു? Christina. Okay, good. Okay, so my girlfriend has no mental retardation, but only cherry red lips. Very good. Okay, only cherry red lips, no cherry red spot. Okay, fine. Okay. Now, no visceromegaly. Now, no, let us see anything else will come out of you. No visceromegaly. I'm going to list it out, okay? No visceromegaly. Tay-Sachs, Crabs, metachromatic leukodystrophy, plus Fabry's also. ഇതിനെന്തെങ്കിലും പറ്റുമോ? Rs 57. You are Django today. Also Christina. Good. And all the others who contributed. Great. Yesterday, like in my revision channel, I have given a challenge. ഒരാൾ മാത്രമേ reply ചെയ്തുള്ളൂ, but still I gave a challenge of putting some flashcards on type 1, type 2, and type 3. So I've put it in my Insta also today. In that one thing which I could find interesting is type 2 hyperlipoproteinemia. Type 2 hyperlipoproteinemia is a disease of 2. Okay, that is type 2 hyperlipoproteinemia. You remember where is the enzyme defect? Type 2 എവിടെ enzyme defect? അയ്യോ മറന്നുപോയോ? കരണിനോട് ഞാൻ പിണങ്ങി എന്ന് പറഞ്ഞേരെ. അജ്മലിനോടും പറയണ നല്ല ക്ലാസ് ആയിരുന്നു, ഞങ്ങൾക്ക് ഒത്തിരി, എനിക്കും കുറെ ഇൻഫർമേഷൻ കിട്ടി. താങ്ക് യു സോ മച്ച്. ഓക്കെ, പറഞ്ഞേ. ടൈപ്പ് 2 ഹൈപ്പർലിപ്പോപ്രോട്ടീനിയമിൽ വേർ ഇസ് ദ ഡിഫക്റ്റ്? ഓ, മെസ്സേജ് വന്നല്ലേ, ഞാൻ കാണാത്ത. ഓക്കെ, LDL receptor. So what is the lipoprotein elevated? LDL. And along with that, what is the lipid elevated? Cholesterol. Okay, okay. അത്രേ ഓർത്തിരിക്കുക, അത്ര മതി ഓർത്തിരിക്കുന്നത്. The rest is very easy. It is a disease of 2. Like two hearts together to form a couple, right? So that is coronary artery disease. So it is predominantly, you can see coronary artery disease in type 2. That is one thing. Then two eyes are there, two corneal arcus. Then Achilles tendon. So two tendon xanthoma, Achilles tendon, tendon xanthoma. Then xanthelasma. Two eyes are there. So xanthelasma around two eyes. So this is a disease of 2. Two hearts together, coronary artery disease. Then two eyes, xanthelasma, two corneal arcus, two tendon xanthoma. So that way you can remember. Okay, fine. Okay, yesterday somebody shared it with me. So I find it better that I should share it with you as well. Okay, fine. So, Tay-Sachs, this is a challenge for you. You find out which are the disorders in sphingolipidosis where there is no visceromegaly. You can help me. ഇപ്പോൾ ഒന്നും കിട്ടുന്നില്ലെങ്കിൽ you can message me later. എൻ്റെ നമ്പർ ഉണ്ടല്ലോ അല്ലേ? Challenge accepted. Yes, good. Challenge accepted. You find something for me. No visceromegaly. Something very interesting and catchy. So, okay. മടുത്തോ ഇന്ന്? നിർത്താം അല്ലേ? എനിക്ക് വിശക്കുന്നു. നിങ്ങൾക്ക് വിശക്കുന്നുണ്ടോ? I'm hungry. Where is Navajeevan? Oh, hungry. Ab is hungry. Always Ab is hungry. Grab something I am seeing. Grab a snicker. Grab grab a snicker. Grab a snicker. Oh, okay. That is to eat. I thought it's a mnemonic. Yeah, I have a snicker. Okay, hungry ആയി, നമുക്ക് വെക്കാം, നിർത്താം. Okay, hope you enjoyed. മെസ്സിൽ ഫുഡ് കഴിയുമോ? അയ്യോ പോയി വേഗം കഴിച്ചോളൂ. Okay, yes, of course. So I hope the class was not so bad, even though it is not a face-to-face. Thank you so much. You all made it so beautiful for me. Thank you so much. Love you all. Bye. ടൈം സെയിം ടൈം, ഓക്കെ, 6 o'clock. എനിക്ക് കോളേജിൽ നിന്ന് തിരിച്ചു വരണം. റൈറ്റ്, ബൈ ബൈ. അപ്പം നാളെ ഞാനിത് ചോദിക്കുവേ ഒന്നും കൂടെ ഈ സാധനങ്ങൾ. I will ask you about this sphingolipidosis. Love you so much. Bye bye. Yes, me too. Bye. ഓക്കെ, വേഗം പോയി കഴിക്കും. മിസ് യു. ടുമോറോ കൂടെ കാണാം. നാളെ ഇത്രയും സമയമൊക്കെ ഇരിക്കേണ്ടി വരും. വേഗം തീർക്ക്. കുറച്ച് അമിനോ ആസിഡ് ഉണ്ട്, റീകോമിനന്റ് DNA ടെക്നോളജി ഉണ്ട്, പ്ലസ് മ്യൂക്കോപോളിസാക്കറിഡോസിസ് ഉണ്ട്. നോട്ട്സ് തരാടാ തമന്ന. താങ്ക് യു സോ മച്ച്. ബൈ. പ്യൂരിൻ മെറ്റബോളിസം ഞാനൊരു നോട്ട് തന്നില്ലേടാ സാംസങ്. ഐ ഹാവ് ഗിവൺ യു എ നോട്ട്, ദാറ്റ് ഇസ് ഇനഫ്. പ്യൂരിൻ മെറ്റബോളിസത്തിൽ ആകെ പഠിക്കേണ്ടത് ലീഷ്-നൈഹൻ സിൻഡ്രോം, ഗൗട്ട്. ഐ ഹാവ് ഗിവൺ എ വെരി ഷോർട്ട് നോട്ട് ഓഫ്. Okay, bye. Bye, Christina. Bye, Ars. Bye, all who actively participated today. Thank you so much. Bye-bye. വേഗം പോയി കഴിക്കൂ കേട്ടോ. ബൈ.